Thank you very much indeed.
Just ask you to use your right hand button to switch the mics on when you're speaking, and then again from afterwards.
Right hand button.
Yeah.
Right, good afternoon, everybody, and welcome to the joint host. The 24th of October 2023. You're all most welcome, and thank you for all attending, because I know you're all very busy people. Before we start the meeting, one or two things. I'm obliged to inform you this meeting is being live streamed and recorded. And please, can I ask anybody who speaks to introduce yourself clearly so people listening in know who is talking. That's okay. I'd like to welcome everybody for coming. The duration of this meeting is 2 hours, and we've got a lot to get through on this agenda. So I would please ask if people can try and stick to the questions or the information and not drift off on in tangents. Any questions that we don't get answered, or we feel that we'd like more information, I'd like to either have a follow-up meeting at some stage, or we'll send those questions out. So in the hope that we can request and get some written answers to them. I think it's important that we get the information that we're all willing here today to work together for the same aim. So I think it would help if we do run out of time, that we consider a follow-on meeting or sending out follow-on questions. But that's to be discussed after the meeting. We'll see how we get on. Apologies for the for people. We've got apologies from Simon Fozell,
Who is actually here?
Oh, that's good. Sorry. You can see that. Okay, thank you. And Lynn Corley. Councillor Kate Halliday and Heather Kidd have sent apologies for attendance, but are both hoping to join the meeting remotely. Heather is presently at Windsor Castle getting her MBE today, so that's congratulations to her. But she still said she could try and log on from somewhere. Okay. Okay. To summarise, the committee have invited attendees here today to understand the challenges in the health and care system in Shropshire, the actions being taken to address staff's performance, and the outcomes expected. The initial lines of questioning have been provided ahead of time so that questions can be planned and answers given ahead of time. As I said, we've only got 2 hours. Yep, okay, thanks. We've only got 2 hours, so we need to move on. So we've got a declaration of interest. Anybody got anything to declare? No, fine, thank you. Move on. Minutes of the meeting held the 4th of July 2023. Have you all seen those minutes? And if so, do you agree with them? I need to propose in a second to agree. You're proposing, David. Yes, thank you. Anybody want to second those minutes on the 27th? Thank you very much indeed. All those in favour of accepting them, thank you very much indeed. Okay, what have we got now? The Shrewsbury and Telford Hospital Trust performance. to scrutinise the historic and current performance levels at Shrewsbury Hospital Trust and how they are being supported by the local and national system. How do we go from there? Ollie? Sorry? Oh, of course, I apologise. Thank you very much indeed. Introductions, so we all know who's who. I'm Jeff Elner. I'm the co-chairman of this joint host together with Ollie from Telford, and I'll be chairing today's meeting. Do you want to go around this way?
I'm Sophie Foster. I'm Overview and Scrutiny Officer for Shropshire Council.
John Jones, Executive Medical Director at SAF. Good afternoon, Nigel Lee. I'm the Director of Strategy and Partnerships at SAF.
Good afternoon, everybody. Simon Whitehouse, Chief Executive, NHS Shropshire, Telford and Wigan.
Hello, I'm Louise Barnett and I'm the Chief Executive at SAF.
Hi, I'm Sarah Biffin, Acting Chief Operating Officer here at SAF.
Hi, I'm Helen Trewell. I'm the Director of Finance at SAF.
And I'm Hayley Favour, I'm the Executive Director of Nursing at SAF.
Good.
Derek White, Telford Region Councillor.
My name's David Sandbach. I'm a co-opted member from Shropshire Council.
I'm Louise Price. I'm a patient representative on the Joint Host.
And Dave Saunders, Clock Speaking, Telford and Wigan.
Oh, sorry, should I go? I'm Hilary Knight. I'm a lay member at Telford and Wigan Council.
Thank you.
And I'm Simon Foregate. I'm a optee for Telford and Wigan Council.
Thank you.
I'm Amanda Holyoak, Committee Officer for the Committee taking minutes.
Lorna Gordon, Democratic Services Officer for Telford and Wigan Council.
Lauren Page-Staffy, and I'm the Senior Scrutiny Officer.
Good afternoon, my name's Ollie Vickers. I'm the co-chair on the Joint HOSC and the vice chair of Health Scrutiny at Telford and Wigan Council.
Good.
We've got some people online as well, Chairman.
Online we have. We'll do this yourself, Kate.
Yeah, Kate Halliday. I'm a Shropshire councillor, a member of the Joint HOSC.
Thank you very much. Rachel.
Hi, Rachel Robinson, Exec Director for Health for Shropshire.
Right. Who else have we got? I can't read it. Claire.
Hi everyone, Claire Hobbs, Director of Nursing, Clinical Delivery and Workforce at Shropshire Community Trust.
Thank you very much indeed. Anybody else? What's her name?
Horsfield.
Oh, Claire Horsfield. I can't read it. I apologise for that.
No worries. Good afternoon, everybody. So Claire Horsfield, Director of Operations and Chief AHP from Shropshire Community Health Trust.
Thank you, and you're most welcome. Thank you very much indeed. Okay. Just for the record, and for the minutes, I want to say that NHS England were invited to this meeting. They will not be in attendance, as Simon Whitehouse and his team will be answering questions on their behalf. But I just wanted to put that in the minutes in case anybody queries why we've not asked them. I assure you we have, and I assure you they accepted. But it's pointless having two people saying the same thing. So they're not here today, but I wanted to put that in the minutes that they were asked to come. Thank you very much indeed. What's happening? What are we doing now? Right, okay. We're going to start on questions. What we decided we would do would work better is instead of questions here, there, and everywhere, we're going to work on topics and so on. So Ollie is going to ask the first question on our first topic, which is what help? Where does it say? Quality improvement and CQC ratings.
Thank you, Chair. So the first question, what help has been provided to SAF by NHS England to improve since 2018?
Thank you. So the trust was placed into special measures in 2018 and then migrated into the National Recovery Support Programme in 2021. And during that time, we have had support from the National Support Programme in a number of ways. That has included some funding to the organisation to support activities that we've been carrying out in order to improve the quality of care for our patients. So that could be funding specific roles or providing expertise to support our team so that we could make improvements. We also went into a partnership arrangement with UHB, a hospital in Birmingham, and they were also able to support us during that period. The support that we get from NHSE is continuing, and we are still in that recovery support programme, and indeed the system are also benefiting, and we continue to be funded and supported in the quality improvement programmes that we take forward.
Thank you. The committee understands that University Hospitals Birmingham were brought in by NHSE to support staff in their improvement. Just a few questions on that. What were the specific issues and points for improvement that support was required for? Why was this trust chosen? What help exactly was provided? What was the cost of this support? And what was the impact of this support as well? Thank you.
Yeah, thank you. At the point that UHB was appointed as a improvement partner to the organisation, we also had a new chair of the trust, Katrina McMahon, who's our chair today, who was a non-executive director at that organisation, and also Hayley Flavel, who's our director of nursing, who also worked at that trust. So we had significant support both from those individuals, and Hayley is now appointed as one of our directors at SAF permanently, which is fantastic. In terms of specific support, there was a role for them in terms of oversight of our quality improvement programme, which had 9 different areas within it. They also supported us with the leadership capacity that I've identified, and also enabled us to draw on some of the activities and processes that they had in place at that time, so that we could learn from other organisations, both that organisation and more broadly. We had particular individuals that worked with us that supported us to take forward change. In terms of the cost, I can't comment on that. That was an arrangement between the organisation and the regulators, so I'm not able to comment on that. And in terms of choosing the organisation, again, that was a decision made by the regulators. Thank you.
Thank you. David.
Yes, thank you, Chairman. You said that NHSE funded you for quality initiatives. How much?
I would have to check the exact amount, but
Millions or a couple £1,000?
it would be certainly several £100,000.
That was spent on?
So that was spent on a series of roles. Do you want to give some examples of that, Hayley?
So
Thank you.
I came in September of 2020, and we had some funding for quality matron roles, which are still within our organisation now. So we funded them substantively. So we've got 2 quality matron roles. We also put some significant support into dementia support. And also falls, so just to name but a few. We also put some additional support with our safeguarding team as well. So there was lots of things that went on a broad quality perspective, but looking at specific roles, we had some very targeted work and focus in some of those areas as well, David.
Okay, thank you. You do realise, of course, that UHB is one of the worst performing trusts in the country. So what did they teach you?
I'm happy to come in. Sorry, I've got very good presentation. You might be suppressed that. So one of the things that we worked with UHB a lot was regarding our governance processes. So John and I chair a meeting called RALIG, which is a review and learn from incidents group, and that was a very established process that was at UHB, and I was a deputy chief nurse at UHB, so that's been adopted We've obviously ensured it fits staff and the needs of staff. So that's one example. And also some other further governance developments, clinical governance developments that we have adopted within our organisation.
Good, thank you. David, would you put your mic on when you talk?
Sorry.
Please.
Um,
Thank you for that.
I think that's all I need to ask at this stage, but I did raise my eye when I saw that UHB wasn't one of the better performing outfits in the country, but there we go. Thank you, Chairman.
Thank you. Before we get to David, Kate Halliday. Kate, you want to ask a question?
Yeah, thank you, Chair. Yeah, I was just wondering, thank you for the answers provided so far. I think in terms of the bullet points of the questions, which I believe everyone can see, could you say a little bit more? You've described the process, but could you say a little bit more about what the impact of the support has been in terms of, you know, how it's affected patients?
Yes. I think there's a couple of examples I'd give. One is in terms of the way that we were organised in terms of our structure. So we organise ourselves into divisions, and we've been able to appoint medical director and a chief nurse, a divisional nursing director, and an operational director to each of those, in order to make sure that we've got the focus on the delivery of services that we needed, and that all of the key issues relating to patient care could be overseen effectively, and we could ensure good focus on our Getting to Good programme and draw on that and deliver improvements. I think linked to that as well is the governance process, and I'll bring Dr. John Jones in here because that had very significant benefits, and in fact we have continued with these structures of learning and embedded them further. Thank you.
Yeah, thanks. So John Jones, medical director. So I think it's about consistency of approach. So if we take, for example, what Hayley's already drawn attention to Brown Lake, so it's a consistent approach to incidents affecting patients, so you can be confident that we're hearing all the things that are happening, that are identifying the really serious classes, and we're investigating them appropriately and taking action. So we've got a really consistent way of doing that now. I think linked to that, we've developed a much stronger governance around, for example, learning from death. So we've got quite an infrastructure so that we look very systematically in the way if a patient died in hospital. Of course, dying in hospital is very common, but making sure that we learn both, did we do things well from during that patient's time with us, or were there things to learn. So I think it's a consistency in identifying what's happening in our organisation, how patients are being cared for, and how can we develop the learnings and actions in association with that.
Thank you, Chair. Could I just ask a follow-on question? Thanks. Yeah, I'm just interested because we've seen presentations where we've seen action plans and, you know, red, amber, green, and whether certain processes have improved. Is there an actual kind of measurement in terms of patient outcomes attached to this funding, or is it more about the processes?
So I think a really good point, because I think measuring outcomes, there's always a temptation to be drawn to the things that are measurable. Actually, the really important things around caring for patients are really difficult to measure in numbers, etc. Obviously, we're very what's very easy to view with when things go wrong. What we're trying to do is to identify outcomes in terms of things that go well. That's much more difficult. Sometimes that's about what others describe about their experience with our organisation, and there's certainly evidence from both our, although we're talking about being adequate, both in terms of our formal assessment with the CQC, that there were improvements in many areas on our last report, and of course we're currently in the middle of a CQC visit at the moment. But also in terms of some of the organisations, particularly, for example, linked to maternity, describing the experience of our families. So we get qualitative information through other organisations. Clearly, we get measures of infections. We get measures of time people spend in hospital, which is a measure of quality. But it is quite difficult in terms of numbers to be really precise about outcomes. I'm sorry if it's not a really precise answer, but much of it is about what people tell us, particularly patients' experience, what people tell us about the experience in hospital.
Thank you.
Thank you. Derek, you first.
Thank you very much. Firstly, I can say that thank you very much for coming on here. This is the best attended NHS meeting that we've had for many years, and it is long overdue. And I hope it won't be too long before we don't have you again. And you've got to forgive us because, you know, we've been struggling to get talking to you. So therefore, some of the questions were fairly basic, and we're going back to where we started. And the finance particularly interests me. Now, Shropshire has always been known to be one of the low funding NHS supporters. We've never had what we believe was a fair share for Shropshire, and we've struggled ever since I've been on Scrutiny, which is many, many years. Now they brought in this team to help you, support you, working with them. You're not sure why they were brought in, and as we've already heard, that they're not the best team that they could have brought in the country to actually give you that support, although they probably have provided that support. Was there any cost at all to the trust? Was there any money paid, or did NHS pay for it themselves? Was there any cost to you?
I think this relates to UHB, doesn't it?
Yeah, could I just clarify? Do you mean in terms of the cost of working
the cost of bringing in the consultants and everything else?
No.
Nothing at all? No.
We didn't have to pay for that support from UHB. We may have contributed to salaries, actually, where we were drawing on individuals. I'd have to double check that, for example, like Hayley. But effectively, the general support, which was the aim of the agreement with them, in the governance areas that both Hayley and John have described, no, we didn't.
Right. Can I just add to that? I mean, and it goes without saying, I understand the anxieties in relation to a particular partner. We've got a very strong director of nursing out of that relationship, and I'm going to highlight that now because she's undoubtedly, I've been in the organisation a long time, she's undoubtedly the strongest and most patient-focused director of nursing we've ever had. So that to go on record. So if there's any reference to UHB, I'd like that is a really important finding. And if that's the only benefit, and I'm not saying it is, that is a really strong benefit for the people of Shropshire at Telford and Wrekin.
You get bills from oysters. I don't like oysters. So there's good and there's good. I'm glad that we've got something really positive from that. There seems to be honest, many, many years and trying to get you back to us and talk to us and listen to you. Why have you struggled to come to talk to us?
I came to see you.
I don't. Yeah, I absolutely, Hayley, you did. Absolutely did. Yeah.
So I don't think, I mean, sorry, across the system and across health partners, then my understanding is there's been different representatives coming and having different conversations across a number of themes. So, Hayley's already said she came and talked about maternity. One of my directors came last time and talked about the challenges of winter and what that looked like. Look, I think we met with the chairs on Friday. I think there's absolutely a commitment for us going forward in terms of the relationship that we have both with the individual OSCs as well as the joint HOSC in terms of that space, and a commitment to work to both understand the work plan, make sure we've got the right people in a timely way. What I can't comment on is lots of looking back beyond the past 12 months because I wasn't in the system before then. I can talk more importantly about what our commitment is going forward, and our commitment going forward is to make sure that we're around the table both formally and informally to support and develop the work and to continue to bring the transparency of the work and the improvement work that we're driving across the system.
Thank you.
And I'd like to second that as well. That is the feeling we came over to be very, very strongly with the meetings we've had. There was a willingness to work together. And rest assured we're going to. Thank you, Louise. Did you want to just...
Yeah, I would just echo that, actually. I mean, we are really committed to working with you, coming to the committees as appropriate, and working with you behind the scenes. And, hopefully coming with the team today is a demonstration of that. Yeah, thank you.
Good. It is. Thank you, Dag.
Yes, thank you, Chair. Can we look at a couple of issues within the CQC ratings? And obviously we're looking back to 2021 and the CQC account is coming around at the moment. First one is safe. Reds right the way through safe. I mean, this must be amazing disappointing. If patients want anything, they want a safe service. But A, how disappointed were you with that rating? B, do you expect that rating to change this time round, and what have you done to ensure that happens? And the second bit of it was the end of life care. Again, desperately disappointing result on end of life care, and link that with the medical care, including older people. Again, worrying thing. Particularly look at the population of Shropshire, Telford, Regan, and Paris, who look to the hospital for basic services. So again, would you expect end of life care ratings to change, and what have you done to improve them? And how disappointed were you to get that rating? Thank you.
Before you answer, Derek, can you turn your mic off?
Oh, sorry.
Yes, yes, I hope so. In the previous inspection, we did make some significant improvements. However, in the areas you've identified, we were rated as inadequate, and those have been, along with the other areas actually, the focus for us over the past months and time. We are in the middle of a CQC inspection currently, and they will be re-rating the areas that you've identified, because they've come into a series of core services, and it includes end-of-life care and medicine and urgent emergency care. We've certainly been making we've certainly been working hard to make improvements, and if I just pass over to Hayley, she could give you some examples of those and the work that we're doing. Thank you.
Right, thank you. So you're absolutely right. We don't want to be an advocate for any of our core services at all, or our overall core domains. In terms of post and end of life, there's been a huge amount of work. We've got some really strong leadership in end of life. We've got a consultant called Dr. Emma Corbett, who is our clinical lead. I'm the executive lead for end of life, and we've also got a very strong matron as well. There's been a huge amount of work in terms of improving palliative and end of life care offer, because that was one of the things when the CQC came in, because palliative and end of life spans a period, and one of the challenges that we had was, how do you navigate that period of time to make sure the right services are going to the patients at the right time? So following on from the inspection in July 21 is when they actually visited us. We've now got a combined team which is really integrated. So we've got that palliative and end of life care offer. We've also got a lot of training. We've also have work that, so we have training in terms of academia, and we have training in terms of equipment, but we also have on the spot, on the job training. So our palliative end of life care teams go out and work with our clinical teams, and that's how it should be. We've also done an awful lot of work on life care after death as well, because that's equally as important. We, as Louise alluded to, we have had our CQC colleagues in a couple of weeks ago. We are still in the middle of a live inspection. However, we did have some initial feedback, and that initial feedback did demonstrate significant improvements in lots of areas, notwithstanding we've still got a long way to go, but did demonstrate some significant improvements. And it was noted the significant improvements in palliative end of life, because I was interviewed as part of that process with Dr. Corbett and with Matron Cooper as part of the well-led. And that's also been commented because the people who interviewed us, who were part of the inspection in 21, were the same inspection team, which is really helpful, if I'm honest, because they can see those improvements. So I hope that answers your question.
Okay, thank you.
Thank you.
Thank you, David.
Can I go back to
Mic on.
sorry, what was saying, Dr. Jones? My interpretation of what you're saying is that you can get the hard data, the numbers. Everybody knows I love numbers, but philosophically, you're moving towards quantitative assessment of what's going on. Not only that, but you're going for quantitative assessment and getting a very rapid turnaround of that at the top of the office, so that you basically have a better feel for what's going on. Is that the new policy?
I would say it's policy. So no, I think it's a bit of both. I think you need both the quantitative and the qualitative. So you need numbers, and you also need the descriptive. The trouble with it being entirely reliant on numbers is you are reliant on things that can be measured, and people's experience of hospitals is each person has a different. Nobody's the same, and I think sometimes an emphasis on numbers can encourage people not to forget the actual experience of people waiting for an appointment in hospital, waiting for that, and it's really difficult to describe those individual experiences in terms of numbers. Numbers are important, and you'll know. So we have a consistency of data that we receive through to board. And part of our integrated performance report, which looks at things like high level things like overall mortality, as well as some measures around infection control, measures around preventing complications in hospital. We do get data with that, but it's quite difficult. Other than it's good to see that our standardised our mortality rate compared to peers is in the kind of at or just below where you'd expect it to be compared to peers. But that doesn't tell us that everybody who comes into hospital and sadly dies is cared for properly, and therefore we can't. That's what I mean by not relying on numbers. We have to do what I talked about, the learning from deaths work. So that's very much about both getting feedback, verbal feedback. In the reports, you'll often see comments from families, but also it's a systematic way of looking for opportunities that you could have cared for people better, but also highlighting positive ways. But that's nearly always qualitative information that comes out of that. We've just got to be intelligent about looking at it and recognise that we can't always explain that very well.
Chairman, there is a saying that stories are data with soul. And I think that part of your philosophy has changed, and probably because of you.
No, we're very much all in this together. So I think that's one of the things that I've noticed about, and I have been in the organisation a while, although not in this role, is that everybody sees everything as their responsibility. So it's nice of you to say so, but I'd like to spread that out a bit.
Can I just come back to the UHB issue? You formed a committee in common.
Mm-hmm.
Did you produce notes from that, and were they ever circulated in public?
There was minutes taken at the committees in common, and they did go to the board. I can't recall whether it was the public board.
They didn't go to the public board, otherwise I wouldn't be asking the question.
Yeah, so there was minutes produced.
And are those now available? Now that the deal's over, are those available? Would you like to think about that?
Yeah.
The other question, I'd like to follow up on the CQC results. I've looked at them, and basically they prove a shift. Not an overnight shift, but they do. However, I had a look at the CQC ratings going back to 2014, and the trust has never produced an overall score better than requires improvement. You've never had you've had a couple of greens occasionally in certain areas, about 3 in that period. But essentially, this community has had a trust that never gets past, requires improvement. Now, if you look at the CQC webpage, you will see how many are in different groups. And the group that you're in, there's only 1% in that group at the moment because you're in the red group. Yeah. But when you look at the requires improvement, there are only about 17 or 18% in that. So for all these years that CQC's been coming, you've never broken out. And I don't think people like that. They want outstanding because we pay Well, we hand in, correct me if I'm wrong, Mr. Whitehouse, it's about £1.1 billion is spent with the ICB. 91 million-ish goes to primary care, and the rest comes to the rest of you. You're taking around about £500 million a year, are you? Yeah. So that's a lot of money, and we've not got the goods. Thank you, Chairman.
But we will. Can I just ask before we move on, within quality improvements and CQC ratings, before we move on to performance, one of the questions that I have written there to ask and nobody's asked it yet is what will happen if SAF continues to be inadequate and still does not improve? Can anyone answer that question, please?
So the system will continue to be in the oversight framework rating 4, which is what we're currently in. We'll continue to work with the national intensive support team, and there will be the further conversations in terms of what does the recovery plan look like in terms of moving that forward. You'll recognise that the changes that have taken place since 2022 with the formation of our integrated care board, the integrated care system, because I think, this picks up on some of David's point as well. There is a responsibility of system partners as well as the responsibility of SAF in terms of actually what's our responsibility to the residents of Shropshire, Telford and Wrekin, Chair, and to drive the improvement in one part actually is connected and linked to our other partners as well. So it's really important that we look at that in the round in terms of where we're trying to improve to and where we're trying to get to. And so there are absolutely responsibilities that sit with colleagues to right, left and right, but equally responsibility with Shropcom and Robert Jones and Angus Hunt and the Integrated Care Board and Midlands Partnership in that space at the same time. So it will be a revisit of the intervention that's currently in place, a revisit of the confidence in terms of the delivery of an improvement plan, and the revisit of the support that's currently being put in place to determine what that looks like. But we're already in the lowest oversight framework, which is National Oversight Framework Rating 4, both at a system level and at a SAF level, so that we're already in the maximum amount of support that's currently offered nationally.
Thank you. Louise, you wanted to comment?
Yeah, just to again link back to your points, David. I mean, we are here because we're absolutely determined to move forward in getting the organisation to a good rating. Ultimately, that's what we want to achieve, an outstanding. We are some distance from that, but we believe we've made some really significant improvements. We do, however, still have some very significant challenges. So we would take stock if we were to be re-rated as a trust as inadequate, and there would need to be further discussions about support to the organisation, because ultimately our community absolutely should have the best possible services, and that's what we want to achieve. So I think we will wait to see the outcome of this inspection. But meanwhile, we're working hard every day to try and move the organisation on and actually achieve a rating which isn't inadequate, and then deal with every individual rating, because there's many individual ratings, and actually you could end up being in a situation where you could have a requires improvement rating as a trust, but still have inadequate ratings potentially, and similarly you could move forward to good. So we are determined to do that, and as you've identified, we have made some progress as per the previous inspection. We believe we've made some significant progress in terms of this inspection, but that would be for the CQC to determine as opposed to us, and we will continue because we are here for our community and we absolutely want to provide the very best care for our patients, and that matters to us. Thank you.
Good, that's nice to know, nice to hear. Quickly, because I want to move on to performance. Louise.
Thank you. I was just wondering, what do you think is the main reason why you've been receiving such low CQC ratings for so many years, when other trusts that are in areas of much greater social deprivation have been achieving much higher?
Well, that's a really difficult question, isn't it? I think my observation is that I think we probably concentrated too much on trying to provide individual areas of siloed good care and not joined it all up. And I think that might be the history. And whether that's, you know, we've got we have 2 acute hospitals. We've had lots of different commissioning arrangements. We've got 2 countries involved in where our patients come from, and we've got all the, you know, the rurality, but we don't have all the difficult issues that other areas have, and I just don't think we've necessarily thought about linking it all together. And there is an opportunity, I think, with the integrated care system to kind of start again with all that. But I think that's it. So throughout the last 20 years, there'll be examples of where we provided really clear, high quality care, both through what patients have told us and also through numbers. You know, colorectal cancer management is a good example. But we just haven't linked it all together. So where one bit of specialty is good at something, I don't think that's necessarily been shared very well. And I think some of our systems around getting outside of individual how we look at things that go wrong, we haven't looked at it across the patch, we haven't learned from each other very well. And I think that's probably a bit of a consistent thread that's run through both in the hospitals, but I would say wider in the healthcare economy. So that's my observation. But hopefully, as I say, there's an opportunity with another reorganisation with integrated care systems, I think perhaps to be a bit broader in our outlook.
Thank you. Can I just say that whatever performance improvements you do, they need to be consistent, don't they? They need to, and what I gather, or what I think you're saying is they're not always consistent.
Yeah, not always consistent, not always shared. I think we tend to often run a bit silo-like probably over the years.
Good, thank you. Can we move on to the next section, which is performance? The first question you probably already answered now, which was, or is, the committee would like to understand why SAS performance is consistently below national standards and is repeatedly reported as being amongst the worst performing trusts. We sort of alluded to that with questions from other people, but is there any comments you'd like to make directly about that question that you haven't already commented on?
I think I'd probably just like to add that our hospitals are full at the moment, so we've got every bed open in both trusts, in both sites, and we've also got a number of patients who no longer require acute services or require services of social care. So that's about 150 patients in our hospitals today that don't need to be here. So what we've got is an overcrowded ED, our emergency department, and then obviously we've got patients who don't need to be in hospital. So what we've got is we're gridlocked basically, and so our flow out of our ED departments is not what we would want it to be. We are working with our teams to make some improvements, so use of other facilities like our same-day emergency care, like our acute floor where we refer patients up to, but it's not enough. So what we need to do is work with Simon and his team and obviously our Shropcom colleagues to be able to stop patients coming into our hospital that don't need to come to our hospital, that can have services elsewhere. But also, how do we improve our flow from our bed base so that we get our patients out much quicker? So there's some work that SAF needs to do, absolutely. And then there's obviously work that we need to do with system partners to be able to improve the way we operate.
Are you talking system partners, you're talking social workers?
Local authorities, both our Shropcom colleagues, yes, rapid response teams, ShropDoc. So everybody within the system, we need to work together.
So there's ongoing work.
Absolutely, yeah. And what we've got is we've got an urgent care improvement plan where we're all working together to improve that. So there are a set of improvements that belong to staff, and then there are a set of improvements that are within other providers or in the local authority. So yes.
Okay, thank you very much for answering that one. Right, the next question. What are the current? Okay, carry on. Who was first? David.
If I was representing NHS England, I would remind the committee that what has just been said will be said around every scrutiny committee board across the country. Everybody's jammed full, but pretty much the same reasons. Can't get people out, not enough space not enough staff, not enough resources. So, and that's one of the things, if I'm perfectly honest, that exercises people, that the playing field is the same for you all, but you guys always end up at the bottom of the pile. And given the nature of the health status of Shropshire people, you should be in the middle of the pack, not at the bottom. So, I'm sorry, Sarah, but the excuse that you're full and busy, that is the same for every other trust in the country. And yet they perform, they're not at the bottom of the pile, they're slightly higher up. I think that has to be said.
I'll take your point, David. I think where we're probably different, people can correct me, is that our no criteria to reside is higher. It's not 1 in 4 of our beds are occupied by patients who don't need to be in our hospitals. There is work that we can do. There's absolutely, as I've said it before, the use of pathways or alternative pathways. So rather than patients coming through ED, they can have direct access pathways into oncology. We can have direct access pathways into orthopaedics. That's the work we're currently doing now. The challenge we've got is our infrastructure and the space. So again, we're working about how we can create that space, because you're right. Everybody has got the same challenges. We are just a little bit behind in terms of doing all of that improvement work that we need to do. So I'm very committed to work with our improvement team and with the divisional directors, medical directors, and our nursing directors to be able to do this. So I've got an action plan that details all of this. Is it going as fast as I want it to? No, not at all. But we've got to do this, because those are the commitments that I've made to the public. So that's what we will do. It's just slower than I would like it to be, but we can't get away from the fact we are admitting patients we don't need to admit, because there's not an alternative elsewhere, and we're not discharging patients as quickly as we should do. So those are, so I'm working on the discharge side of it and the alternative pathways. But you're right, these are challenges across the country, but I would say we're slightly different in that our no criteria to reside is 1 in 4 of our beds are occupied.
Thank you, Doug.
Yeah, can we just clarify, Sarah, a little bit of what you said? 150 people currently, you changed the title, it used to be.
They used to be called medically fit for discharge, and now it's called no criteria to reside, so they're the same thing.
The bulk of those waiting for a social care assessment, or waiting for a placement or domiciliary care, or as a joint hospital, we look across the board. So we need to really understand where the real problems are. Understanding that there's a big national issues in terms of social care anyway, and that local authorities are very strapped. But do we know what the real issues are in relation to those 150 people? Are they evenly spread across Shropshire, Telford, Powys?
Yes.
They are.
Yes.
What are the real issues about getting people
so the issues
who don't want to be in hospital?
Yeah.
Really.
So yeah, absolutely. So we've got 150 patients that are medically fit for discharge, of which about 100 of those are ready to go today. So if there was capacity in social care, whether that's domiciliary care, nursing home, reablement beds, whatever it may be, they could go today. The other 50 are waiting assessments, so waiting for an assessment from one of our physiotherapists or OTs, or nursing assessment of about what is the right placement for those patients. So physically today, there's just over 100 patients who could leave either PRH or RSH today. So it's an equal split really, sort of 30-30, 33-33 in terms of pathway, going home, going to a reablement bed, or going to a nursing home or residential home.
Yeah, thank you.
That's pretty dire, isn't it?
So if those 100 patients were in their appropriate place of residence, that would then help us to deliver the ED performance that you mentioned. Yeah. Because at the moment, I was on call on Sunday. It was a very challenging on call, whereby we have completely overcrowded EDs. We do not want to afford care in areas that are not appropriate to afford care. However, we do, because what we have to do is ensure that the risk in the community is also mitigated. Because if we've got ambulances that are sitting outside our hospitals, those ambulances are not then going to the calls that are in the community. So it's a very difficult balance, because what we're trying to do is mitigate risk both within our organisation for that overcrowded ED, as Sarah's alluded to, and also the risk in the community. So it is an absolute nub what we need to address in terms of notwithstanding the work that we need to do internally with our systems and processes, but those 100 out of those 150 patients need to be somewhere else for their onward care. Thank you.
Kate. Thank you for being so patient. Kate Halliday.
Thank you. Yeah, for the question one, does organisational culture play any part in the ongoing issues that SAF's performance has had? And, you know, I think people's concerns about Birmingham Hospital Trust are linked to the fact that they've had a number of inquiries going on into their alleged failure to listen to whistleblowers, etc. So I think on the back of the Ockenden report last year that has identified similar issues, I'd be really interested to hear from anybody about whether the culture within SAF has contributed to any of these issues.
Yes. I think culture always plays a part in improvement work. I often say, you know, we employ about 7,000 members of staff, and that'll be a cross section of a whole range of people, personalities, and we should therefore expect all the sorts of problems and challenges that any large organisation will have had, but the risks are obviously greater within something as critical as a healthcare organisation. And you'll know there's been, and then you've alluded to it, there's been not just in particular hospitals, but all nationally concerns in relation to sexual harassment and assault. If you look at the recent Royal College of Surgeons report, but also ongoing concerns about bullying and whether people in management positions listen. I'll be completely frank, and this is my personal comment on that, is that it is in my kind of personal drive as well as my personal interest to listen and act on concerns that are raised, and I can't think why I wouldn't. There is sometimes a sense of being overwhelmed with all that's happening sometimes in the wider healthcare system, how everywhere's full, as we've already alluded to, and just that kind of pressure around the harm that we know is caused in the community when people can't, an ambulance isn't arriving for them. And that does sit with us, and we talk about the impact on us personally and having it being accountable for all that. But yes, we are taking action to support good relationships, avoiding bullying. We're going to be a pilot site for a support program, particularly focused on surgeons for when things are going wrong, to help them respond and learn from that and go on to be productive surgeons. We know that we listen more to our staff in terms of developing ways of doing things. I've alluded to, I think maybe I haven't, but things like the robotic work. So even when the trust that's in the ways that David's been drawing attention is struggles in certain areas, we still are trying to listen to our staff to move forward and provide the latest quality of care. And then the robotic surgery is a really good example of listening to staff. It was a really hard financial sell to get that through, but quality and providing the most up-to-date care for our population was the thing that drove that through. So yeah, I think there are, in terms of the harassment side, I'm as confident as I can be that we act coming back to consistency, we act in a consistent way when concerns are raised about bullying or harassment or poor conduct. But the assessment of that will come through how people describe their experience of both working with us and being cared for by us. And we know we've got a long way to go. Staff survey, for example, it's going to take, I suspect, a long time before we see significant traction on that. But that, in the end, what matters is that people's experience. It doesn't matter what we think patients should think of us or what staff should think of us, is what they actually report. Yeah, so I still think we've got a long, we have got a long way to go.
Thank you for answering that. Simon, then we've got Derek, who's thank you for participation. Simon.
Yeah, thank you, Chair. So just to bring a few of those strands together, I think, because, the question's a key one, and John's touched on this already anyway. There is a real importance now that the focus is on how do we deliver better integrated care across pathways for the residents of Shropshire, Telford and Wickham, and that's not solved just in what happens in the emergency department. That's as much across what's our responsibility for prevention, how we're working with both of our local authorities, voluntary community sector in that space, so we can start to shift that demand curve. Sarah equally has absolutely articulated the importance of the improvement drive that's within SATSGIFT in terms of their responsibility to make timely discharges, as well as the need for system partners to play their part. But at the same time, everybody's recognised the acute site configuration and the estate limitations are a contributing factor in terms of how some of this works as well, because nationally, the government wouldn't have put the £312 million support ready to deliver the hospital transformation programme if there wasn't really clear recognition of the contribution that the estate challenges make to that and the challenges of delivering that acute service across two district general hospitals with the workforce challenges that are very different now than they were several years ago. So I think it's absolutely appropriate to focus on the patient experience bit, and that's absolutely right. And everybody sitting around this table and partners online and elsewhere is committed to saying, how do we improve ambulance response times and how do we improve an individual's experience in Shropshire, Telford and Wickham? But we've got to stick to the delivery of the improvement plan that Sarah's articulated, and that includes every partner playing its part in terms of delivering that, and then the delivery of the hospital transformation programme as part of that as well.
Did you answer the same?
No, it was just to clarify.
Okay, then quickly.
Yeah, it was just to clarify in relation to the UHB, the University Hospitals Birmingham support, that we were grateful for the support, for example, Hayley and Katrina, and also the ability to draw on things like clinical policies and approaches in that way. We actually had a different trust support us on maternity improvement, which was Sherwood Forest. So I just wanted to clarify that. And also, in terms of the culture change work, we had significant support from the national team. So we're able to link in directly actually with some really fantastic people around engagement to build our culture change programme, which we've been continuing over the last couple of years. Thank you.
Thank you for explaining that. Derek, thank you for being so patient.
Simon, we've got 150 people in the hospital that don't need to be there. It could be better served out in the community. We've got primary care are not fulfilling the function that they should be doing, which is prevention. People going into hospitals in the first place. We've got a whole system here. We've got the councils who can't provide the care when they leave the hospitals, and that's why you've got so many people in there. Surely the job of an integrated health system is to actually start to overcome all these problems and work with each partner and help them finances. Councils, and we've already seen a sort of questions from David regarding the costs and how the hell they're going to be expected to cope, because they're not going to be able to cope and deal with this. And this is going to be an ongoing problem with people being in hospitals, being looked after by staff that shouldn't be looking after them. We know all about the virtual wards and all the rest of that, and whether that's going to be anything. But we need to actually have a relook at the whole system, and that's what integrated care system is all about. Taking it from grassroots, helping the doctors be able to cope with the normal necessities, and they're not coping in, I don't know anywhere that is, in primary care, we've got community care where we've got I don't know if we've got enough staff nowadays, but we're expecting damn sight more people in there to be able to be looked after, and whether that staff is going to be available. We've got a hospital where members of people who are highly qualified are walking past our hospitals in order to go to jobs in Birmingham, Wolverhampton, Stoke. And that is because our performance is so poor. But that really now comes back to you as the leader of the integrated care system to actually start sorting these problems out.
What in that, councillor? So if I don't pick all of that up, then you'll come back to me, I'm sure. So on a significant answer to that, I would say absolutely agree. And what Dr. Jones said earlier was there's an opportunity to reset with the formation of the integrated care system and the integrated care board being put on a statutory footing, the opportunity to look at the whole system response to a number of these challenges. And I think what you've heard from colleagues is a commitment to have that whole system conversation. One bit I would come back to you on, I guess, would be I think there's a shift even before we talk about the role of general practice. And I touched on that in my response in terms of prevention and the work that needs to happen in communities and how we encourage people to look after themselves and to make good decisions and good choices in life. And that's a collective responsibility. That doesn't just sit with one partner in terms of that. So I think the work that is being driven through 2 health and wellbeing boards around that prevention agenda is really important. I mean, that will be the biggest turner in terms of that demand curve. We also know how we deal with long-term conditions and how we do that in a much significantly more integrated way. Will both improve outcomes and will deliver improved use of resource, both staff and otherwise. The staff conversation, that's not just about the performance piece. The staff conversation is about the facilities to work within, the ability to feel as though actually we've got that joined up coordinated system where we're making a real difference and added value. And so that's normally, from when you speak to staff, it's multifactorial in terms of that. And actually, we need to be dealing with all of that. So John and Hayley have talked about culture, confidence, ways of working, but absolutely how our teams are configured and what does that look like. And equally, the work that is happening now in the community around the local neighbourhood teams and how we get general practice, community services, voluntary sector, local authority colleagues working to look after the population in that area is a key part of the strategic intent going forwards. And that's got to be about how do we keep as many people safely in the community for as long as we can. I guess my final point would be, I think, and as I'm saying this, I'm saying most of this I agree with what you were pointing out in terms of the importance of an integrated care system going forward. That's part of why we're here, I think. I guess my final point would be that there's a really important bit here with, whilst we can talk about no criteria to reside, we can talk about the number of patients that turn up both at general practice and an emergency department that probably don't even need to be in either general practice or the emergency department in the first place, as much as those that are sitting in hospital that no longer have needs for acute care. So at every strand of work, we've got to make sure that we've got both the routes and the access and the support in place that enable people to make really good decisions about where they access care, timely intervention in terms of that, and that we start to tackle the demand curve in terms of prevention. Some of those are easier to fix than others, but none of those are fixed in isolation. So the commitment towards working as a system, I think, is absolutely paramount in all of this.
Can I just ask you, are we too small? We're the smallest, one of the smallest in UK.
Yeah,
Are we too small? Have we got the poorest funded? So we've got a hospital that's struggling so much. Are they in danger of being taken over? Are you in danger of being taken over?
Are we too small? I think we come step back a piece. And if you look at the 42 integrated care systems across the country, you've got a range of both geography, population size, and demographic challenges that look across that. When you look in terms of how the much bigger ones are working, they're saying, how do they work at a lower level to make sure they get the connections in place? So for me, almost irrespective of the size, that bit makes very little difference actually. The important bit is how do we get the delivery of integrated joined up care that Dr. Jones has talked about, given we've got one acute trust, one community provider, specialist trust, mental health trust, and 2 local authorities. That's absolutely within our gift to improve the way that we deliver joined up care to the population and the residents that we serve in Shropshire, Telford and Wigan. And that would be if we were in a 3 million ICB population and we were working across 4 or 5 or 6 local authorities, the conversation would come back to what do you do at a local level around a population of 400,000-500,000, and how do you build up from there? So I don't think the size is the issue piece. Whether there'll be another reconfiguration. I mean, I think the current government clearly put integrated care systems on a statutory footing with the revision to the Health and Social Care Act. And thus far, I've heard nothing from the opposition parties and nothing from the current government that would indicate in their manifestos going forward into a general election there's any intention to change that. But I also recognise that governments have that opportunity to revise the Health and Social Care Act at any point in their government policy period.
Thank you for a very detailed answer to that one. David?
Clearly quite a complex set of variables and conundrums there. When are you going to deliver on it then? When are we going to get a better service? You're the guy that was saying all these things. When does it all come together? When do we get a hospital service that isn't always at the bottom of the pile?
Health service.
And David, if you think I'm going to sit here and say by the 25th of January in 2026 the answer is going to be this, then you know I'm not going to be in that space. What you've heard from Louise and colleagues already is an absolute commitment to the continued improvement. We've got the CQC in now, and we need to see what that brings back in terms of a direction of travel in terms of where that's at. There is not going to be in the system a quick fix where somebody flicks a switch and says that bit's now all sorted and it's all in a better place. We're really clear on the priority areas that need to demonstrate that improvement, and through the integrated care board, through the plans that are being put in place, there's clear improvement trajectories and clear improvement plans with a focus on some of those key areas. Some of that is reliant upon the delivery of the hospital transformation programme. Some of that is reliant upon making sure that we've got the right workforce to meet the needs of the population. And some of that is reliant upon making sure that we're working with local authorities and voluntary community sector, and that we've got strong employment, and that we've got some of those really clear Marmot principles, because otherwise we know that drives demand in healthcare that's outside of the NHS's control. The biggest bit that makes a difference to the health and well-being of a population is people's ability to have a decent job, make good choices about their lifestyle, and have a decent home to live in. That's good education, and a friend actually as well. You can add into that. And that's
a nice family.
And that's 80, not necessarily the family, a friend. That's 80% of what determines your health and well-being as you age. Of the remaining amount, the actual NHS intervention is really small. However, our commitment is to drive the improvement across all of our services, general practice, in terms of the acute trust, community services, to make sure that we're better meeting the needs of the population. And you've heard that. Well, you know there's not a flick of a switch on a date.
And you've explained that in a plan, have you? You've developed a plan that says to the public, these are all the bits that have got to be stitched together, but when we do it, X will happen, and it'll happen, say, within the next 5 years.
And some of that is absolutely set out in the joint. I mean, there's a question later on, so I recognise I'm covering some of the later questions, Chair. That's set out in the joint forward plan, which is built from the integration strategy that's done with both local authorities, really heavily supported by both directors of public health, and then that's turned into an operational delivery plan that happens on a 12-monthly basis that covers operational performance, workforce and finance.
Okay. Thank you. Before we move on to the next question, can I just insert a supplementary one that has been written? It's clear that the Guardian system is not currently effective? There are hotspots and poor behaviour and bullying within the system. What can be done to address this immediately? Anybody want to?
Just some point of clarity, Guardian, is that specifically related to the Guardian and Safe Working? Is that another Guardian? Big speaker, sorry, yeah. I mean, I think, I mean, I've said a few things about this before. I think, you know, bullying is a feature, is a feature in the health service, and will be, and occurs in hospitals because they're big organisations. That I know, I'm not, Ria's not here, our workforce director, to talk in more detail about it, but I know that we, through Freedom to Speak Up, that our ability to staff to anonymously raise things if they feel unable to through a different route has meant that we are better sighted on what's happening in our organisation in terms of relationship between colleagues. I think we're having a much better understanding of power relationships and the importance of just because somebody isn't your line manager doesn't mean that there isn't an imbalance of power, and that's a particular feature I think that comes out of some of the concerns around sexual harassment, for example. So I think we are generating a better understanding of what our staff are experiencing, and that has been a big part of the last 18 months. And you'll, I haven't got the numbers in front of me, but in terms of the very high levels of activity that we've had through our Freedom to Speak Up. But the next layer is, yeah, what do we do about it? And cultural change does take time, but all I can say is that we are highlighting this, we are addressing, and we are acting in a consistent way when concerns are raised about individuals who have been bullying or harassing. But yeah, we've got to the Guardian Service is working in the sense that it is providing us the information we need, but it's not telling us yet that it's all gone away. And I'm not expecting it ever to say that it's all gone away, but clearly it needs to be better than it currently is.
Is there increase in people talking to you about their claims they've been bullied or upset, or
Yes.
it's now easy for them to talk to you, but there is an increase, is there?
So from a Freedom to Speak Up perspective, we have a paper that comes to board quarterly, and we can see absolutely all of that information in terms of the themes, professional groups. But there's more than that, because it's all very well knowing what's happening, but what and the so what. So what are we doing about it? So that is also what forms part of the paper that comes to board. It's public board. It is public board, isn't it? Mm-hmm. Public board, thought it was. Public board in terms of what outcomes and what outputs have we done differently as an organisation to address this. I agree with Dr. Jones. We're never going to take it all away, but what we need to do is have a culture within our organisation that people feel safe to speak up. Now, I can't wholeheartedly say that everyone feels safe to speak up now, but what I can wholeheartedly say is that we've got routes and methods where people can raise concerns. We have got freedom to speak up. We've also got an executive team who are really open and approachable for people to come and speak to us as well if they feel that they want to. And John and I only met somebody last week because we want to be those leaders in the organisation where we support all of our teams, if they are clinical teams or not, because obviously clinical teams would come to me and John. But there is an awful lot of work that's being done within the organisation for those foundations, but there's still an awful lot of work to do.
Thank you. So in fact, you're dealing with it, put it that way. You're not it's happened and you're aware of it. Thank you. Okay, can I move on? The next question is, what are the current cancer performance levels and how do these compare to the patterns over the previous 5 years?
Thank you, Chair. So our cancer performance is improving. And obviously following the pandemic and COVID, patients chose not to attend hospital. It's not that we cancelled cancer services at all. Patients chose not to attend. So we've got a backlog of patients that we need to treat. As you can see from the pack that I put in the pack, you can see where we're on a downward trajectory in terms of our backlog of patients. So we are improving the number of patients who are waiting over 62 days for their treatment. And also where you can see also is the other standard that we're monitored against at the moment is 28-day faster diagnosis. So patients must be diagnosed whether they have or haven't got cancer and told within 28 days of them being referred from their GP. So you can see from the trajectory that we're on an improvement trajectory, and our latest performance is that we're ahead of trajectory on that standard, and we'll meet the standard by the end of March 2024. So it has improved. We've still got a lot of work to do in particular areas. So our improvement plan, again, we've got action plans with each of the tumour sites and what they're going to be doing to improve. But also we're working really closely with West Midlands Cancer Alliance, who are supporting us with some people and also some financial support in order for us to be able to deliver the targets going forward. So yes, we are on an improvement trajectory. 5 years ago, we were in a much better position within SAF. We were one of the high achievers of cancer targets within the region and nationally. But obviously, following COVID, we've deteriorated, but we're now on an upward trajectory.
And that's your target to get back in?
Absolutely, yes. So the target over the next it's 18 months now, is to get back to where we were previously.
Good. Thank you very much for your detailed answer. Dave?
Yes. Can we look a little more at cancer services? Obviously, it's an area that people have major concerns about. I think you said that's your top priority. In fact, I think you said in one of the papers. Just looking at the current performance, yes, things have improved. I think you're currently rated on national level of 105th out of 120 trusts in terms of performance, but that's an improvement from a little while ago where you're down to 110, I think. So it is improving. But what are the real, to look at what some of the challenges are, there's a background of financial difficulty. Now, quite often when finances start to bite, the first issue that goes out the window is the programme maintenance. And that has a lot to do with replacement of equipment, etc. So are there issues in terms of diagnostic equipment? And are there issues in terms of manpower to support that, because there are national shortages over technicians and other support staff, consultants particularly? Are there issues within that you're having to face and having to deal with? Or are you as staffed as you wish to be? Have you got any problems with equipment, maintenance, etc.? What are the issues that basically that are still keeping us down, although an improving position, but still towards the bottom?
Yeah, so I think where we were short of equipment, we've now invested in that equipment. So we've got mobile CT scanners, mobile MRI scanners. You'll all know about the Community Diagnostic Centre that's in Telford, which will give us some additional capacity. We've invested in more MRI and CT scanners on the RSH site, and we've done some international recruitment for radiographers. So we've still got gaps, definitely got gaps, but we are definitely improving in terms of that. We've also got a new endoscopy, 3 endoscopy rooms. Two of those are now in operation. We've just got one that isn't in operation. We've got a business case in place at the moment that we will be presenting sometime in November with regards to having that recurring funding so that we can get all 3 of those endoscopy rooms up and running, which will mean investing in our staff as well. So yeah, so we have invested a lot in cancer services over the last couple of years. And obviously, we've also got the robot, which John alluded to, in terms of, so we're now doing robotic surgery as well for colorectal and urology and gynecology.
I briefly answer that. Yes, Christian. Just coming back to one of the recruitment, so oncology is definitely a national recruitment challenge, particularly locally. So cancer treatment's become much more specialised. So you don't tend to get kind of general oncologists now. So you get oncologists who specialise in particular cancers, and yes, that is a challenge. That is a challenge, and I think will continue to be for some time, simply because it's not a specialty that's got a lot of people coming through training programs for. So that's something that we're very mindful of, and as I say, subspecialisation has meant that more difficult, because if you lose one. If you lose 1/8 of your oncologist, that's you haven't lost 1/8 of your capacity. You potentially lost 100% or 50% of your capacity in a particular cancer area. So that's something that we remains a concern, and working with the oncologists trying to support them, because they're doing a lot of work.
And any indications of urology or neurology coming back into Shropshire? You're still looking outside.
Neurology with an N.
Both.
We can both comment on this, but shall I start? I'd say so. Urology. I'm really pleased with the partnership they got UHM. It's exactly the right thing to do. And the robot, we're getting a robot, I think, to be honest, it saved our urology service. I think we could easily have lost urology because you have to have the latest equipment to attract people.
Yeah.
And particularly when it comes to something like cancer robotic surgery is essential. I think it's a positive partnership. It's solidified the service, and just because it's linked to another organisation, to me, it's very much a local thing.
Okay.
I think I'll just make the distinction, if I may. So urology, that still provides urology services. We provide those locally. What we are doing is doing that in collaboration with UHM, particularly for the specialist areas. And with Sarah and colleagues, we've developed that operational relationship, particularly for the robotic surgery. So we work on a combined relationship through that because it's specialist commissioned. So, and as John said, that work, being able to get the robot, look at that as being a massive benefit for the recruitment of staff, and to be able to provide that specialist surgery locally for local patients is really important. For neurology, and again, John will add, I'm sure, this is beginning with N, the neurology. This is an area which is, again, a significant national shortage specialty. Neurologists tend to prefer to work in the larger neurosurgery and neurology specialist centres. And so what we did working with the CCG at the time, actually, and RCS now, is look at how do we provide local services for patients, but do that in a sustainable way. So a number of our staff, specialist nursing and support staff, are still combined with that service. We now get that service from Wolverhampton, but the service is still provided locally for local patients. It's just part of that bigger set of capacity, particularly medical capacity. And collaboration, I think. Sorry, I will probably just beat the drum for that sort of broader strategy. There's a bit of a question there about that broader clinical service strategy. Where we want to provide local services for local patients. We want to do that in a sustainable way, but we also want to do it in the best possible way. Networks and making sure that we work together to achieve best practice and sustainable services, which is really, really important. So we will be looking to try and do that in the most sustainable way.
Good, that's nice to hear, because local services are very much wanted by local people.
Yeah.
Nobody wants to go to Wolverhampton, however lovely Wolverhampton is,
And HTP, and Simon alluded to that. The opportunity to provide sustainable care for urgent and emergency services is obviously really, really important. But so too is planned care and cancer services, and the ability to create dedicated space for that. And again, that means you've got really, the opportunities for real centres of excellence, to increase that and focus on that. So that's absolutely part of the plan. It's just as important.
Excellent, thank you. Right, moving on. Question 3. More specifically, has there been any deterioration over the past 3 months? If so, what plans are in place to rectify this?
That related to cancer.
Or anything?
Yes, cancer chair.
Yeah, so
Answer about half cancer.
Yeah, so we've seen an improvement over the last 3 months in terms of our cancer performance. And as I talked about previously, we've got a series of deep dives into each of our tumour sites to ensure, and they're clinically led, to ensure that we are implementing best practice pathways, which we are doing across a number of tumour sites. So yes, so there's been an improvement in our performance, and we'll continue on that improvement trajectory.
Good, thank you. Next question. In the financial year 2022-2023, how many level 3 and level 4 critical incidents have taken place within the trust?
Sorry, it was on cancer. You mentioned that there's actually quite a lot of cash going in, capital and revenue, into the cancer and to the effectively the diagnostic part of your organisation. I think it would be to your benefit and to our benefit if you shared how much has gone in, what you bought, and what you expect that to deliver in a simple table, so that everybody can see that because that's good news.
It's good news.
Thank you, Chairman.
Thank you. You're right. It is good news. Okay. Do you want me to read that question again?
No, that's fine. No. So between April 2022 and September 2023, we had 15 critical incidents within staff across the two sites. And the reasons why we have those critical incidents is that we've got an escalation framework which runs from escalation level 1 to escalation level 4. And when we've done all, when we hit escalation level 4 and we're still not offloading ambulances and we've got an overcrowded ED, we have a set of triggers that then say we need to declare a critical incident internally because we need to be able to de-escalate our ED departments and offload our ambulances, because when our ambulances get to a significant weight or over 60 minutes is what we monitor, but when we can't offload ambulances, we're into that critical incident territory, which is obviously where we do exceptional actions and look to support from our system colleagues as well to be able to help us to de-escalate as quickly as possible. And that can be as a result of that we've got an overcrowded ED, which I talked about, where we haven't got any resource capacity, so resuscitation capacity, and we have got low levels of discharges across the trust at that time.
Can you give an example of what actions, an action that you took that improved things?
I think it's where we've taken action is to improve our patients who are discharged onto the virtual ward, because that's one of our improvement interventions. And so within that critical incident, we have seen an improvement in the number of patients that we discharged onto the virtual ward. So what we're doing now is to say, or what were the actions that we took in order to discharge those patients to the virtual ward? How do we sustain that and make that business as usual, as opposed to being something that when we're in critical incident that we do. So that's where we're trying to improve on that.
So in effect, you're learning.
We're learning, yeah. And every critical incident that we have, we do a debrief. So that's led by our emergency planner. And we do a debrief about what went well, what didn't go well, and what can we do better going forward, and what did we learn from it. And what we do then is take those actions from that and put it into our action plan, our UEC improvement.
Thank you for that. Doug.
Yeah, so I should know the answer to this question. Does critical incident include never incidents?
Never events.
Never events.
So
Really never events.
never events, not included. So have there been any never events in the trust in the last 12 months?
I'm just looking at John.
Yes, so we report numbers at board. I wouldn't like to say the exact number because I haven't got it in my head, but yes. We have.
So, sorry, just for clarity, we do report it as part of our integrated performance report that goes to public board. It's part of the incident section. Those also go through that, the process I talked about an hour and a half ago in terms of rally, the review and learning from incidents group. They all go via that process. So going back to what Dr. Jones was saying, it's about the consistency. So we have had a number, it's a low number.
Have they been going up recently or
no.
They're quite intermittent, so
Yeah.
I think without having the numbers in front of me, it's quite difficult because you'll get one in a month and then not. And then that's why I'd like to be able to give you a really precise answer. I just don't have the figures. Yeah, we can come back.
Chairman, I look at these.
I know.
They're random and they can cluster. The ones I worry about when they cluster. Thank you.
And you're absolutely right what you said, David, that if we have anything of a similar theme, we will always revisit the previous investigation to make sure that, as you said, they're not clustering and we are learning. But that is very much part of our governance process, and we have that open honesty at board about those processes. Thank you.
Nigel.
I think, if I may, Dag, because notwithstanding the question about never events, just wanted to make sure that we were clear. So as Sarah described, there's a national framework of escalation. So level 1, level 2, level 3, level 4. And then when the triggers are met, as Sarah described, there are times when a set of triggers mean that we go into what we call a critical incident level. So that is different to an actual, for example, a clinical incident or another event or whatever.
That's a very new structure, isn't it? It's just been changing this.
Yeah, that Sarah will know better than me, but this is under the National Emergency Preparedness and Resilience and Response Framework. As I say, that's built on then the national, what's called operational performance escalation program.
There are elements as well, though, isn't it, Nigel? So yes.
Yeah, I was just trying to keep it nice and simple of there is a differentiation between operational escalation getting to a level versus clinical incidents, and obviously with those sort of significant.
I'm just going to mention, you probably read it in the newspaper that we had in March. We was a children's generator. Was it June? So it all goes very quickly. So in June we had an incident with our generator in women's and children's, and that again that instigated a critical incident. So there's a threshold, as Nigel rightly said. It's not all around the emergency department. A lot of ours are because of our challenges. But yes, would you like to comment?
Yeah, so again, recently we had another estates-related critical incident as well. So they're not always around overcrowding in ED. Sometimes we have estates issues, and that just means that we can't continue our business as usual. We work through what we're going to do, and then we can step that critical incident down.
Thank you. Very quickly, we are, I know we're all enjoying ourselves, but we're 3/4 of the way through, so we've only got half an hour, and we've got quite a
Very quickly, Chairman, I'm looking at Nigel. You've given us a number here. How does that compare to other hospitals? Have you got more or less or the same?
Is this, sorry, the level of critical incident?
Critical incident.
Oh, right, so I'm going to need to defer to my expert.
More.
Pardon?
It's more.
More than others?
Yes.
How much more?
A lot more.
A lot more?
Yeah.
Do you want to give us the numbers?
I haven't got the numbers, but I can.
Would you mind sending them in?
Yeah.
Thank you very much.
Brilliant. Thank you very much indeed. Can we move on then to service development? First question, the committee understands that as part of the hospital transformation programme, there are plans for a new oncology and haematology ward with the provision of 32 beds, which is an increase of 2 beds over the current provision. Does the trust and the system believe that this future bed provision will be sufficient to meet future demand, especially based on the projected growth in population and especially the older demographic, which is to the forefront of that growth? Whoever wants to answer it, I'm not.
So under the as part of the work of the hospital transformation programme, there's been a significant what's called capacity and demand analysis that's been taken. That primarily looked at the next 10 years, but also used a variety of different other information, such as I know that Cancer UK has done some projections on this. And I think that was, if I'm right to saying it was 6.7% in this area up to around the 2038 perspective, which when you look at the 30 beds that we've got and then the 2, I think it's 2.0 something that 6.7 means. I think there's 2 or 3 other factors I would point to. We know that there'll be a certain requirement for inpatient provision. As part of the new plans, oncology and haematology, which is in the ward block in Shrewsbury, will be provided in the new build in the plans, and that means there will be a significant amount of single rooms, and that in itself helps length of stay and the provision of treatment. The second bit is that, and again, John will know far more about this than me, but if we look 5 years ago, 10 years ago to now, and then project that forward, treatments and options for patients continue to develop. And my brother, unfortunately, has just been receiving treatment for this exact area, and all of his treatment has been done as a day case. And so the ward and the inpatient ward is absolutely part of the provision, but so too is looking at other places and other ways in which we deliver the treatment for patients. So the day case area, which is at Shrewsbury, will be maintained, and within the HTP plans there is also a day case chemotherapy centre at Telford, which will provide, and will continue to look at, in the way that Brian described, the opportunities for integrated care, for doing some of the support to these patients in the wider community as well.
Good, thank you. In addition, then, how long do you actually think the 32 beds are going to be sufficient for?
Yeah, what I just tried to mention was that the initial demand capacity is for that next 10-year period, but the it also aligns with the Cancer UK projected demand out to 2038-39. So it's in that initial time frame, but we'll continue to monitor that. And that would be done as part of the broader work as we look at the strategic development as a system. I know that there's work looking at capacity demand, again, in the strategic sense that Simon and colleagues within the Integrated Care Board are doing, and that is also linked aligned to that.
Really answered that. Thank you. Thank you. I think we've addressed the next questions already on committee understand that both urology and urology specialised services are now being delivered by other trusts on a hub and spoke basis. I mean, we've really mentioned that previously.
Yeah. Can I just intervene on that? My assessment of what's happened, like over the past 40 years, because that's how long I've been working in Shropshire, we seem to lose things across the border. And I'll give you an example. You're always on the threat of that, because not long ago there was an issue about doing emergency aortic aneurysms. Does anybody remember that? You will, because you were here. And you beat it off, didn't you? Because a lot of people that like working in big city high-tech centres came down and said, oh, you should be sending your treble AAs to a centre. And that does work in certain parts of the country. But because you had numbers to treat and your quality was good, your outcomes were very good, you managed to beat them off. But one of the worries I have, strategic worries, is that you will be put under pressure to lose the really exciting stuff to somewhere else, the really difficult stuff. And I just want some assurance that is there a policy of SATH ending up as a spoke rather than a hub? And if you've got a hub policy, what do you want to be the hub for?
Shall I start, John, and then perhaps you could come in? I think, firstly, we're really committed to the principle of care close to home and providing services that our community would need close to home. That is where we want to be. I think we recognise that with workforce challenges and the size of teams, in order to be able to do a really good job, learn from each other and provide all of the care, that we may need to group things together. So it may be we need to organise ourselves in a particular way to do that across our hospitals. It may also be that for certain things that are a lot more complicated, there are certain things that we would never attempt to kind of repatriate here, because there will be centres, for example, burn centres, where specific care is provided and it would be in the best interest of patients to travel. But I think for more routine care and care that you would expect to get, then we would want to provide that locally. Where we can join up, as we have done with hospitals in Stoke, for example, UH&M, and work together, so effectively our teams can work in partnership with each other, that may bring a strength to those clinical teams and actually the work that they do. And we can benefit from that, whilst also, as we've given in the example of urology, be able to provide things locally. So we're looking to collaborate, which would help us to do that, whilst having a balance between those kinds of choices. So I understand where you're coming from. Overall, we're not looking to be a spoke per se, but there may be hub and spoke models where there is some very specialist care somewhere, but we're still able to provide care sort of locally. Do you want to come in, John?
Yeah, so I mean, I think this has been at the heart of a lot of the conversations right the way through consultation, HTP, and our whole description about the organisation of our hospitals, hasn't it, for the last 15, 20 years, because we've been, the conversation has been about balancing, trying to provide as many services as possible in your local hospital against trying to be of sufficient size to hold on to services, particularly when you think about development of the NHS cancer plan, where there's some very specific numbers about what sort of population you have to maintain a service. And so if you take, for example, upper GI cancer surgery, so esophageal cancer surgery, stomach cancer surgery, that was really difficult to lose to another centre. I have to say, I found that, perhaps because of my specialty, but realistically, we had no chance. We needed, I think from memory, you needed 1 million population for that. So either we were going to be the centre, or UH&M was going to be the centre. And one of the positives that comes out of that, we have been able to develop benign upper GI, that's the wrong word, benign, but non-cancer upper GI surgery. So we've actually recruited really well into upper GI surgery. So it's meant that we've got the skills for dealing with emergency surgical things in the upper part of the gastrointestinal tract, which is the thing that I was worried that we would lose if we lost the cancer surgery. So there was something that came out of that was positive. So in the end, probably that was the right thing. There are other specialties that I wonder whether maybe in a different time we might have been able to hold on to. I wish we were doing interventional cardiac work, stenting. I really wish we were doing that locally. I think it's a long way to travel, whether it's to Wolverhampton or to having to go in a helicopter off and an ambulance to get you. I do wish we, but realistically, the numbers of people you need to provide an interventional cardiology service, because it's all consultant delivered, meant that was always going to be quite difficult. But yes, that is the one that I think would be really nice to have that locally. If you take other example, oncology, I think geography is really important. I think if we didn't have a local oncology service and people had to travel, people would choose not to travel and therefore not have the treatment. So I think if we had the same population in a more densely populated area, I think our oncology service would probably be more at risk. But I think the geography is so important, because we can't have people deciding not to have cancer treatment because it's too far to travel. So I think that's been certainly our argument all along around things like oncology. I think other areas are really strong. I come back to colorectal surgery, cancers. We've got a really strong, high quality, good outcome service there. But there have been various specialties at different times that we've worried a little bit about, but we want, and much of the really difficult conversations about HTP, and they continue, don't they? All the discussions about how we're going to organise our services. I'd much rather have a service that people have to travel a bit further within our county than have to travel out of our county. And I think that's informed a lot of the really difficult and decisions around that followed through from the consultation, I think. And they're still difficult, aren't they? They're going to be ongoing discussion, but I do think we made the right decision over that.
Okay, thank you, Simon.
And just to reiterate, I think from the Integrated Care Board's perspective that we want and support and will work with to get a really strong, thriving local hospital that meets the needs of the local population, and that is a really important part of any of the strategy that's been developed. John's articulated really clearly the challenges of both medical advancement, workforce, and what that will mean on a service by service perspective. But just to be explicit for the committee this afternoon, we want and will work with and will commit to working to drive and get to a point where we've got really high performing local hospitals that are responsive to and meet the needs of the local population.
So what hub do you feel we should have in Shropshire where we attract in caseload? What specialist area would you go for?
Well, I think John's articulated that much better than I would do, David, in terms of how do we work through on a service by service perspective. So this is about population basis, workforce basis, and needs of the population. And that's how the decisions get taken all the way through this, as the way that John's already spent 5 minutes articulating.
Good. Let me just one thing to that, sorry.
Please.
Just interesting, some services, fertility is a good example actually, about where we're strong. We draw from quite a wide population. So I haven't got all the figures about where from, but we get a lot of. So I think if you could describe it as such, I think probably we are. If there was such a thing as a fertility hub, I think we probably are one. But thanks.
Thank you, Derek.
Thank you. As a reconfiguration of the services. I mean, I was chair when we actually authorised the removal of the stint process, and that ambulance were going to go directly there because the time saves lives and saves long-term effects. But with the reconfiguration of service, the 200 million that has been cut from the reconfiguration, had that any effect on what we were actually planning? We applied for 500 million, and then we ended up with 324. The government told us we had to spend. Had that got any? I mean, that's a lot of money that went down the tubes. What was the effect on our future plans on actually being able to, as David quite rightly says, we should be attracting funders into Shropshire, not exporting people out. And we've got an opportunity of reconfiguring our hospitals. Surely there must be more opportunities than just for fertility to actually be able to get people in and make one of our services there the best there is in our area.
If I may, so I think so we started and the HTP, the Hospital Transformation Project program, would probably be a topic on its own for 2 hours. So we're going to go into all of that. I think so. We were really. I think it's really, really important to remember that the fundamental objectives, the core, what was called the decision-making business case, the core objectives of that were still met, absolutely still met, which was the fundamentals of the reconfiguration. You're right, we looked at the full scope of the programme, and for those of you who've read the strategic outline case, which was published last year, and we've obviously been working through the outline business case, the second phase. So we were really clear that whilst the 312 met all of the conditions nationally, because that was the funding that was available, we have absolutely not lost the ambition for what we want to do going forward, and that's both in terms of the investment in the sites, but also the development of the integrated care opportunities. Because this is, I think it links a little bit to one of Louise's questions earlier on, to what Simon was saying. We do not want to just see the acute services as just about acute. There's a lot of important services we want to do there, but increasingly our role working with the wider system in an integrated way. And that still may mean that the sites, both the Shrewsbury and the Telford sites, are places of work for integrated teams, whether that's community, social care, mental health and others. So I do not believe that the work that we've done so far, the hospital transformation programme and the configuration that we've set with the capital funding available, has limited our services and the way that we want to configure those. We can provide the opportunity by continuing to seek that further investment as we've set out into the business case.
I won't go into the hospital transformation plan, because we never actually managed to look at it as scrutiny. It kept on telling us the business review case hadn't been approved, it hadn't been approved. And that went on for an awful long time. And then it was approved and then rejected by the government very, very quickly. So we never actually managed to discuss that with you. So therefore, we really don't know the full effect of that £500 million that was going to be spent and how it was going to fit. So as I say, the 200 million is actually a major cut in what our plans and ambitions for our NHS. So I won't go into it though.
Thank you, but you're doing the best you can without it, what we're saying. Yes, Louise.
Yeah, there was a number of 312 that was million, wasn't there, which was discussed previously. And then there was discussions from that point about inflation and different things, which is where I think you're getting to 500 million.
That's really
I don't
figures
think,
that we were giving.
yeah, 500 million is coming differently. So certainly since I've been with the Trust, it was important to revisit all this and leave it So we have had our strategic outline case approved, and actually in the strategic outline case, it sets out a series of options, one of which is commensurate with that 312 million. It also identifies other things which are in our overall ambition of what we want to deliver for our community, and identifies different funding sources for those elements, such as the elective hub. And actually we've been able to secure that funding, haven't we, Sarah? So in the process of completing that capital work, so actually we will have the elective hub open, which will be beneficial for patients shortly. And then the further options in that case also set out that ambition. So we're not giving up on that. We're still very committed to bringing about change. And as John has identified, we do need to bring about change because we need to provide thriving, sustainable services. And we know, organised as we are with the estate we've got, we can't do that. So we're moving forward as quickly as we can. And seeking approval through the ventures.
We tried to look at the SOC many times. We kept on going being told until it's approved by NHS England that we couldn't actually look at it. And then when it was looked at, then it was rejected within a very short period of the total amount, and we were told you have 312 million maximum can spend. So it was just, I would have liked to see your ambitions.
Yeah, thanks, Steve.
Okay, thank you. That leads us nicely onto the next set of questions, ICB questions, and I'll pass you over to my colleague, Ollie.
Thank you. I'm just going to take question 1 and 2 together because I'm conscious of time. So what is the time frame that strategic planning in the NHS for Shropshire, Telton Region is taking, and what is the driver for these time frames?
And I think I probably picked up on some of this already, but happy to just go back over that again quickly. We have 2022 Health and Social Care Act reset the planning process for the country with establishment of integrated care boards and with the dissolvement of clinical commissioning groups, put in a number of planning processes as part of that. The first overarching strategy is the integration strategy. That's done with local authority colleagues, done with partners as part of the integrated care partnership. So there's an overarching integration strategy that's been published that's based on population needs. Underneath that, then we've developed the joint forward plan. So that's over a 5-year time period. And so that was published earlier this year and as part of the integrated care board conversations. And that's contributed from all partners. And that talks about how will we deliver on the integration strategy as the overarching framework. And then underneath that, our providers and partners have a 12-month operational plan. That's how do the workforce, the activity and the performance get delivered over a 12-month period to meet the needs of the NHS constitution whilst moving us towards the delivery of the joint forward plan. So hopefully that makes sense in terms of the various strands and how they hang together.
Yeah, thank you for that. And then number 3 and 4 on there, which have been taken together as well. From the minutes of the ICB board meeting on the 28th of June 2023, one of the items discussed was the operational plan and how this plan would now transition into delivery. The chair suggests having conversations with programme board leads about the progress and the risks associated with the work and how collectively we might be able to assist in unblocking them. The committee would like reassurance that these plans complement each other at a strategic level and they address the needs and requirements of the system as a whole.
Yeah, and I mean, hopefully my previous answer reinforces the fact that we start from the needs of the population, which develops the integration strategy, and then the plans then align towards the support, the delivery of that. So, and the Integrated Care Board, of course, has got both local authorities on, as well as having all NHS providers on, as well as Integrated Care Board members. But there's a lot of socialisation that takes place before that and before the sign-off to make sure there's that that it's congruent and there's a clear line of sight.
Thank you. And question 5 has been redacted. We decided, so that's all the questions from me. Thanks.
Good. Well, thank you very much. That's good time. We've got 8 minutes.
6.
I don't think it's worth carrying on with other questions. Are we happy that we wind it up there at the moment? We've got Dag, sorry, Bob to ask a question, I apologise, Dag.
Just to update you, Nigel, I can't find any useful information on critical incidents comparatively across acute hospitals because in terms of case mix numbers, etc. So I can't find anything of interest there. On the Nether incidents, you're right at the bottom with no acute hospital had fewer than one. But the worst in the country, even taking account of the case mix and numbers, was the UHB. Last year.
I think, Sarah, you were going to try and investigate.
I can get the critical incidents from the emergency planning route.
All right.
So I can get.
It's so complicated with the numbers, case mix, etc.
Yeah.
Thanks.
Yes, David.
Yeah, it's not on the agenda, but I was a bit cheesed off. This committee has had presentations about maternity services on 2 occasions. On 2 occasions, Chairman, those people who were present, including myself, were very impressed. In fact, I think I even said that I would have a baby with you.
You emailed me saying you were going.
Yes.
Yes. That I'd like to see.
Well, it certainly makes Shropshire famous. What I am annoyed about is that during those 2 presentations, the committee was not given sight of your neonatal data.
Okay.
Red for 4.
Okay.
Right. And why were we not given that? Because we would have been able to ask questions.
Okay. So
But what we got was everything's sunny in the garden. We've turned the corner. We've got a lot more staff, and you in fact sent us the details of your staffing structure. It has gone up. You've invested about at least £1 million, maybe 2 million more in that service, but we weren't told about this critical piece of data.
So can I come in first?
Yeah,
I'll bring in John. So I came, you're absolutely right. I came initially to speak to you all about maternity, and we were asked to talk about the Ockenden updates. That's what we were asked to talk about. We were asked to talk about what has changed following the publication of the first report and the second report, and that's what we did. We only had, I think, half an hour, so we talked very much about our methodology, the improvements that we made, and some of the outcomes in terms of staffing, leadership and governance. In terms of the neonatal deaths and that information, John, would you mind coming in there, please? Thank you.
Yeah, I mean, you're right to draw attention to both in the West Midlands at large and in babies that are born at SAT. There is an above average neonatal mortality, and it's likely that there is an overlap between the factors that influence neonatal mortality locally as there are in the West Midlands. It is something that we have been trying to understand in a lot more detail. So just to help everybody, so we get information on babies that die within 28 days of neonatal mortality who were born at SAF, although probably around about 50% of those babies dying in the hospitals because of the nature of intensive care type arrangements. So what we know is that we have had above average mortality for a number of years now, and what we have done is both, as you know, the Ockenden review actually had a separate chapter on neonatal care, is that we have used our standardised review tool, perinatal mortality review tool, to understand whether there are things that we could have identified that could have been done differently. Neonatal mortality is somewhat different from looking at mortality more generally, because there are quite unusual things like congenital abnormalities that are obviously unusual for us.
I think, isn't it? Yeah.
I haven't got the precise figure.
49.
I think it's fair to say is that because we have identified themes that might explain it, and knowing there is this wider context of the West Midlands, we have actually got an ongoing at the moment external expert review looking at our neonatal mortality over a 2-year period, just to say to us, look, is there anything that we're missing? We can't wait till the wider West Midlands conclusions. We want to know what the conclusions for our local population. So we're in the middle of that. So I suspect that will finish in the next 2 to 3 months. to see if there's anything we're not seeing. But it's clearly very important. I've said publicly on a number of occasions, what matters is every child death. We need to understand why any child would die, and I deliberately don't talk about numbers, because I think, as I drew attention to earlier, a child death and neonatal death is a total tragedy, no matter how predictable. And I know that families never recover from it, whatever the circumstances. And so we have to try and address every death that occurs on its own, and understand why it happened, and support families both at the time and afterwards. And I don't, the Ockenden Review has drawn attention to that. We haven't in the past done that well at all in terms of supporting families. So all I can say is that we are really looking at it in detail to see, is there anything we're missing? We've got external experts looking at that, and we will listen to what they have to say. And if there was something that I knew that we weren't doing that was influencing that, and that must have been influencing it over a number of years, then we would act on it. The one thing I think is worth highlighting, because it's a broader instance, is the issue of smoking at the time of delivery. We know that we've got quite a high percentage of mums who are smoking at the time of delivery, and giving up smoking is incredibly difficult. And I think we should all do all that we can to support mums and their wider families to try and give up smoking, preferably before they even think about getting pregnant.
You do a good job on that, because you start off at 20 and you get the smoking down to 10 by the end.
About 5 points.
Yeah, well,
I think what's interesting, somebody was drawing attention to me recently that actually the geographical area that Telford and Wrekin, Shropshire generally, I don't think has particularly high smoking rates. So it's slightly trying to understand why particularly smoking at time of delivery is high is interesting. I haven't got the numbers in front of me, but I'm pretty sure that if you look widely at smoking patterns, I don't think they're necessarily particularly substantially high. But if you look at it at the time of pregnancy, there's something there that we need to understand. I think family support is really important. Giving up smoking on your own in a family that smokes must be really, really difficult. So I think there are some interventions that have been done in various parts of our geography around family therapy around that, which I think could be very useful. But you're quite right, all I can say is we're right on.
I must point out to everybody, Trust did in fact make an investment in maternity, and you have a specialist in reducing smoking, don't you?
Yeah.
We also help with an external agency as well, don't we?
Yeah, and it's true that it's 20 and then it drops down. By the time mum delivers, it goes down to 10.
Yeah, it's still higher than where it needs to be. I think the national ambition is about 6%, 5 or 6%. Yeah. And we fluctuate, David, as you will see from the IPR that we take to board each month. And I think last month, John, we were about 10%. So it's still higher than what it needs to be. Because as John said, we need to make sure that we target the mums and the women, but we also need to target their partners as well. Because as John said, it's very difficult to give up smoking on your own.
Yeah, thank you for that. I wonder if vaping has an effect.
I think you're probably right.
There.
You always have that Dad. Okay.
Oh,
I know, it makes you feel, okay. Look, I was fortunate enough to be the chair from the time that we used single hospitals of the HOSC. And effectively, we went all through the Ockenden years. And quite frankly, never once did we hear there was a problem. Never once. And that caused us a huge amount of embarrassment when they came. Not an embarrassment to show, as though we had failed in doing our duty. And again, we get in a situation, and after all the pain you've gone through bloody everything, all the shame that's happened, what's happened? It's still being at a level that is there. That's not being explained or people are being educated about it. It just doesn't seem to happen. Now, we say that smoking is a big factor in this. Again, we come back to the integrated health care, the integrated care community. The one thing it seems to be really lacking, and it's been lacking for many years, is education. All the anti-smoking things have disappeared from the television, the flimming leaflets gone from here. We really need to go back to a situation where prevention through education has to be a factor within the integrated health system. If we can't do that, all we're doing is waiting till they come in the hospital and then saying, you really need to cut down now. By that time, the damage is done.
Aware of time, Chair, but just to come back on a couple of points and turning that. I think the benefit of the integrated care system needs to be just significantly broader than just about what NHS partners can do in that space, because actually that gets us properly into public sector responsibility, both in terms of with our own staff collectively. If you think about how many people locally the public sector will employ in terms of that message, but actually how do we work with education and how do we work with local voluntary and community sector in terms of that prevention agenda. Rachel's dropped off now, but Rachel and Liz are absolutely central to those conversations as the two DPHs in that. But I would agree with you that the reach and the ability of the integrated care system needs to be much broader than just about how it works with its formal NHS partners to get into that prevention space, as I talked about earlier. And that's not just in the smoking bit, that's about the eating, the exercise, all of the bits that sit around the Marmot principles.
Good, thank you for explaining that. Kate, thank you for being so patient.
Thank you. I guess I would really like to thank everybody. I think this has been a really productive meeting, and it's been very good to have this dialogue. And I guess I'd just like to kind of go back to a couple of the points that have been made earlier in terms of, I think, David raised the issue of why didn't we hear about the maternity data in the presentation that we had on the Ockenden report, and I accept the explanation there, but also it kind of goes back to an action plan can be looking really good and the processes can be worked through, but there probably has to be something around the outcomes. And I think ultimately this committee wants to support you to deliver the best care, and we're intimately involved in that process. And I guess this committee would probably rather have heard about these issues not from the Shropshire Star, which is where I first picked it up, but perhaps from you as providers, so that we can work together to actually try to address these issues. Because by not hearing about them, there has been a history in this area of trying to cover things up, etc. And I'm not suggesting that is what you've done, but I think we need to work together to better understand the problems, perhaps as they're occurring, and so that we can work together to put them right. And I do think some of the data and not just the action plans are quite important to this committee. But thank you. I really appreciate every contribution there's been in this meeting.
Good, thank you for saying that. And I also would like to underline the fact that it is always really upsetting when you read something in the paper when you sit on a committee and you should know about it. And I'm not saying that information was held intentionally, but nevertheless, it still hurts when you get information from the public when you should really get it amongst ourselves. That's what we're all about. We're all meant to be working together. So if we could just try that little bit harder, I think, and I'm not pointing fingers at people. I just think it is upsetting, and I'm sure you can appreciate that fact. Right, we're running out of time, so I'd like to give the final word to Louise.
Yeah, thank you. And just coming back to Kate's point, I think genuinely there was an understanding in a short period of time of half an hour to talk about the Ockenden report. I think we would absolutely want to be open and transparent with you about where we are, the quality of care, our ambition to do the absolute best we can for our population, and our improvement journey. So, I mean, there's a commitment there for us to work with you and behind the scenes to ensure that actually you are briefed on key issues and you can therefore work through that forward programme, which we will be committed to with you going forward. And certainly me and my team, I know, will absolutely do that. So Thank you. And thank you for giving us the opportunity to come today. It's been really helpful to be able to talk through some of the key issues we have. We really welcome your support and the role that you play. It's extremely important, and we will remain determined to move things forward in the way we've described. But thank you very much.
Thank you. I was going to ask if you found it helpful. I found it helpful. You did find it helpful.
I mean, part of this, Chair, will be about us building the relationships, won't it? And working together on it going forward. So I think it's a really good place to reset, start. As you said at the start, the commitment in terms of colleagues across this end of the table. There's a reason myself and Louise are side by side in terms of this from a system perspective and from a acute trust perspective. And that our commitment, as Louise has reiterated and reinforced, is then to work in partnership to make sure that this is as productive and as useful as possible to build on where we're at today.
Good. Well, thank you very much indeed, all of you. Your team have done a good job. Okay. But I would like to say thank you, and you're more than welcome to come back. And I hope we do actually reconvene this at the meeting. That's been helpful. Yes.
Thank you, Chair. Very quick one. It does make me wonder, as I've sat and listened with interest, that a lot of this is about a lack of data and a lack of being able to actually understand what the system is facing. And a lot of the data that you do refer to actually does get published in some shape or form publicly. It does make me wonder, is there a way that we could actually develop a data set that could be shared with both MOS, that you could regularly send us updates via the scrutiny officers, who then just keep repeating, populate as the latest bit comes up, that we can all access, that actually might allay a lot of concerns, or get copies of board papers that go and actually talk about progress. It probably would really help and allow us to actually focus on the real nitty-gritty bits that we could really jointly work on. Just a thought.
Yeah, certainly be supportive of doing that, and can work with Simon as well. Thank you.
Good to do. Thank you. On that basis, I'd like to, those of you didn't, and say thank you to everybody once again, and you are now welcome to leave and go and enjoy the rest of the afternoon, whatever's left.
Thank you.
Thank you very much.
Back to work.
Thank you.